To begin our next session. It's going to be on mobilizing domestic resources and fostering political commitments to health, HIV, TB, malaria and protection systems. There's going to be a panel discussion.
Next please. Au thème de cette méthodologie, plusieurs résultats ont été obtenus. Le tableau 1 présente la distribution des infections en fonction du sexe. Il en ressort que le sexe masculin était le plus représentatif avec 67,7% contre 32,3% de sexe féminin. À l'issue, nous avons eu 6 groupes de population, à savoir ceux qui n'avaient que la tuberculose, qui était représentée à 69,33%. La co-infection tuberculose VIH, qui était la co-infection la plus représentative de 17,67%, suivie de la co-infection tuberculose hépatite B de 9,67%, de la co-infection tuberculose COVID-19 de 0,67%. Il faut noter que le faible taux de co-infection TB COVID-19 ici est dû au fait que nous avons fait cette étude après la période post-Covid. Hormis les co-infections, nous avons également déterminé d'autres formes de triple infection, à savoir la triple infection tuberculose VIH hépatite B de 2%, la triple infection tuberculose VIH et COVID-19 de 0,33%. Next, please. No. Yes. Le tableau ci-contre nous présente les résultats des des tests de sensibilité dans la population d'études. Il en ressort 4,67% de personnes étaient résistantes à au moins un antituberculeux, à savoir l'isoniazine, la rifampicine, la streptomycine, et aucun cas d'éthambutol n'était détecté. Nous avons observé une multidrug résistance de 5,33%, ce qui est très élevé. Next, please. Next. Il est à noter que seuls les cas de co-infection TB-VIH, TB-VHB qui représentent notre population phare avec une monorésistance et une résistance multiple. Next. La figure 1 ici contre nous montre la variation des cytokines dans la population d'études. Au premier graphe, nous avons une élévation non significative des interleukines 2 dans la population tuberculose VHB. Et ensuite, nous avons des élévations significatives de l'interleukine 18, des facteurs de croissance et de l'interféron gamma chez les populations tuberculose VIH. Ceci nous montre une hyperactivité immunitaire due à une inflammation de type TH1. Next, please. Au terme donc de notre travail, il en ressort une prévalence très élevée du VIH et de l'hépatite B chez les personnes tuberculeux pulmonaires. Nous avons observé une présence bien notable de résistance chez ces patients et nous avons également dressé le profil cytokinique. Et ces résultats nous interpellent à adopter des stratégies pour pouvoir mettre sur pied, prendre certaines options, des mesures préventives pour pouvoir bien prendre en charge les patients tuberculeux. Nous avons par exemple l'intégration systématique des tests du VIH, du virus de l'hépatite B et COVID-19 dans la routine chez les patients tuberculeux. Le dressage systématique du profil de résistance aux antituberculeux et du profil immunologique chez ces patients. Next. Nous ne saurons terminer sans remercier EDCP Cantam qui a financé entièrement ce projet, l'Université de Yaoundé 1 dont je fais partie, l'hôpital Jameau de Yaoundé où tous ces patients ont été recrutés et le laboratoire de recherche en tuberculose et pharmacologie où ces analyses ont été effectuées. Merci.
Hello? Yeah. Mercy, please give her another hand. So we'll take our next presenter, and then afterwards we'll take all the questions. Thank you. So kindly welcome Mr. Ngou.
Thank you. Good afternoon, all. My name is Justin, and I will be taking you through the journey of my presentation, epidemiological trends of monkeypox and HIV co-infection in Nigeria, insight to accelerate HIV epidemic control by 2030. Next. So monkeypox is not new. However, the behavior of monkeypox have changed since 2017. In the early 70s, Nigeria recorded only 3 cases of mpox, but today it has continued sustained as an outbreak. Those who have HIV infections are disproportionately affected with mpox, and it has emerged as the most important autopox virus since the eradication of smallpox in 1918. Next. Globally, 27 to 36% of monkeypox cases are among people living with HIV and AIDS, and then the mortality is worst for those who have advanced HIV diseases. Those who have not been virally suppressed also experience more mortality. It presents most of the times atypically with some rashes, and then PLHIV who contact mpox should as well start ART treatment immediately to reduce severity. Next slide. So in Nigeria had 1.9 million people living with HIV with about 1.3% prevalence. Among those who are disproportionately affected with mpox are those who we refer as key population who also have a prevalence of about 10.8%, and in 2021 they were among 70% of new HIV infections globally, and then in sub-Saharan Africa they represented about 51% of HIV new infection in 2021. So for us to nip the bud of mpox infection among HIV people living with HIV, our target should focus on these key populations who are the ones who are driving HIV epidemic and new infections, and as well has a poor outcome. Next slide. Next slide. So our objective was to establish a pool seroprevalence of mpox among those living with HIV in Nigeria, and then to look at the epidemiological trends, and then identify key demographic and clinical patterns and its implication to HIV epidemic control by 2030. So our system, we use the PRISMA 2020 guideline. We set the PubMed, Google Scholar, Scopus, and Web of Science, and as well the Grey Literatures. All such items which were eligible was identified. And out of all the 115 search that we got, after screening and removing the uneligible, we use seven articles were included in the review. Next slide. So in our results, among 1,120 who were identified to have mpox, HIV status was available for only 551, And then among that, 59% of them were HIV positive. HIV, those who have monkeypox represented an advanced immunosuppression, with most of them having CD4 less than 200, and then having a viral load that are unsuppressed. Only few has viral load that is below 200. Next slide. So this indicates the intersection of Mpox as we also try to end HIV epidemics that we look at for this. So that slide indicates that while there is underreporting, there is also surveillance gap in terms of those who are monkeypox. So out of the 327 total cases, we found out that 97% of them were male. And then within the age range, so young people are mostly affected. From the study, 31% were the median age, and then male were mostly disproportionately affected. From 62%, which represent the greater number of all the people, had unknown origin. Or like 56 were from MSM and 69 had heterosexuality. The rest did not know where their exposure from. So that is also suggestive of poor surveillance as well as lack of data quality. Next slide. So this 29% of all the people who presented or who were diagnosed for Mpox and HIV co-infection had one or more than one STI at the point of diagnosis. Mostly 37% represent any STI. Then HIV represented 8%, hepatitis 3%, chlamydia represented 15%, gonococcus represent 21%, herpes simplex were 11%, and syphilis accounted for 5% of all the STIs among the 29% who were diagnosed, who had STI at the time of diagnosis. There were similar rates of STI, both for those who are HIV positive and for those who are HIV negative. And there was no evidence of concurrent STI contributing to more severity of outcome. Next slide. So in the clinical pattern of HIV Mpox, we saw that for those who were HIV positive, they had more, they had a severe manifestation, including systemic pneumonia, sore throat, fever, headache, lymphadenopathy, and malaria. Even in dermatological manifestation like genital lesion, perineal lesion, head and neck and face lesion, and extragenital lesion, we are found to be more among those who are HIV positive more than those who are HIV negative. And the severity, like those who are more immunocompromised, like advanced HIV disease, also have more severity of manifestations of clinical signs. Next slide. So, okay, in clinical manifestation, like I said, those who were HIV positive also presented with more severity, more risk of being hospitalization, and then also have a more death rate was also more among those who were HIV positive. Their dermatological manifestation was also more severe. They are most likely to also be admitted and readmitted into hospital. Next slide. So indicator of severity among HIV negative, hospitalization was 12%, whereas among positive we have 33%. So, which were statistically significant. Among secondary bacterial infection, they also have 33% for those who were HIV positive compared to those who were HIV negative. Prolonged illness duration. Those who were HIV positive tend to have 21 to 32 days, while those who were HIV negative was 14 to 21 days. And the median time to onset of disease, those who were HIV negative had averagely of 7 days, while those who were HIV positive had 5 days, within the range of 3 to 7 days for clinical manifestation to set in. Life-threatening complication, 3% were negative for those who have HIV negative, and 9% have more life-threatening complication among those who have HIV, who are HIV positive. The same case fatality rate was more among those who were HIV positive, about 12.6 compared to 1.6 that were recorded among those who were HIV negative. So for insight into, as we work towards ending AIDS as epidemic by 2030, this shows that it has, the one we have shown here, show there is a gap in terms of integrated testing, in terms of surveillance. So as we move towards ending AIDS by 2030, we have to have enhanced surveillance, we have to ensure integrated service, targeted prevention. The data we present have already shown us where the gaps are. The communities where we have not reached with our messages, the places we also need to integrate mpox screening among HIV patients. Some of the rashes, some of them experience, they don't necessarily know that it can be any other things. So while we are intervening, or when we are seeing our HIV patients, we need to screen them for mpox and other comorbidities. Next slide. So I want to acknowledge my directorates, my supervisors, the EPIN management, and then EPIN. These are the Global Health Security team in EPIN. Next slide. Thank you. Let's connect.
Oh, please give him a better round of applause. They both stuck to their 10 minutes time slots. So now the floor is open for questions. If there are any questions for either of the speakers or for both of them, please feel free. Kindly indicate if you have a question. I'll bring the mic to you. So we'll take maybe like 3 questions per speaker, and then we'll give them the opportunity to answer. Okay.
Hi, Diane. You recruited more males than females in your study. Is there a reason why? I think on one of your slides, there were 155 males as opposed to about 55 females.
Oh, please.
Okay, I can say.
Go ahead. Yeah.
Thank you for the question. I did not recruit more men than women. I do sample recruitment, and at the end we saw that men was most represented in tuberculosis patients than women. It's okay. Thank you.
So I have a follow-up based on your answer. Is that to suggest that in the steady population, it was done in your country, right?
Yes.
Is that to suggest that there are more men who are TB patients as per the national data?
Yes.
Okay, sure. Thank you. Please, any other questions? Okay, so I have a question for the second speaker. I also noticed when you're comparing the mpox infections, the parameters between the HIV positive and HIV negative patients, of course, it appeared that the negative patient had better parameters. Was there a control for maybe any underlying health conditions in both groups? Could that have been a confounding factor in the results we saw?
Okay, so
Please.
thank you. So you are looking at if there were confounders. Okay, so well, we didn't, part of other chronic infections like maybe diabetes and the rest were not, we just needed to compare outcomes in both cases. So however, we noted confounder like chronic infections, like those who are diabetic or those who are hypertensive as well during the comparison. And then we also did referrals to eliminate what were the reasons.
Okay, sure. Thank you. Please, any other questions? Okay, there's a hand there.
Yeah, so let me begin by thanking the presenters for the excellent presentation. Question, I don't know whether it has a direct link with what the second presenter spoke about. I'm trying to look at vaccination, that is for those who are HIV positive, that if you want to prevent monkeypox, because there is a vaccination that is being given. If you can comment on that, and then possible outcome of the both conditions, in relation to those who are taking antibiotics. What is their fate like, for those who are having co-infection and are already on antiretroviral?
In the first question, yes, even WHO recommended that those who are HIV positive should be our first priority of target for vaccination against Mpox. So yes, so in terms of vaccination, those who are HIV positive should be our first target to vaccinate against Mpox, because they are the ones that will experience more severity of outcome and then more hospitalization and including death. So in terms of the second question was.
Could you kindly repeat the second question for me?
Sorry, can someone give him mic? Second question he asked.
So what I'm trying to find out, though this is not my area, so you can pardon my ignorance.
No problem.
Individuals who are already on antiretroviral medication and became infected with Mpox, does it affect the kind of antiretroviral they are taking? The medication, do you have to change medication considering the co-infection? That's what I wanted to find out.
Okay, so it's not a straightforward thing. So you may not likely, because there may be other things contributing to before there are other things to put in place before switching of regimen. However, what happened is that those who are already on treatment and those who are not yet on treatment, those who are on treatment who are not suppressed, or who probably have advanced HIV disease, have also experienced more severity than those who don't have. So in terms of switch, I think there are a lot of things the switch committee also put in place for them to say, okay, this person deserves to be switched on regimen. But naturally, I don't think Mpox is very infectious. You can just manage the symptom, and then when the symptom waves, it's possible that the drug can still be. So, but for switch to happen, then other considerations have to be done alongside with the Mpox before switch can happen. Thank you.
Please, are you satisfied with the answer? You are clear now. Thank you. Any other questions, please?
Thank you. Thank you to both presenters. My question is for the lady. So you mentioned about 5% multi-drug resistance for those that will have co-infections. What are your recommendations for that patient population? Thank you.
Okay. My recommendation is to do the anti-drug resistance in tuberculosis patients before give them the treatment. Yes. If I argument more in French, do you understand? Ok, merci. En fait, lorsque ces patients arrivent, généralement dans notre contexte, particulièrement dans mon pays, on fait juste les tests moléculaires pour savoir si la tuberculose est présente. Mais on ne fait pas les tests de résistance. Et parfois, ils prennent des médicaments et ça ne marche pas. C'est après un certain nombre de temps qu'on se rend compte que ça ne marche pas parce qu'ils sont résistants en fait aux antituberculeux qu'ils prennent. Et dans ce cas-ci, il y a plusieurs facteurs qui impactent parce que ça joue au niveau du foie puisqu'ils ont pris des traitements qui n'étaient pas adéquats. Entre-temps, le foie travaille. Il y a également les reins qui travaillent. Alors que si on le fait systématiquement, ça va éviter cela. Donc, merci.
Thank you. Any other questions? If not, we'll bring this session to a close. Please, if you saw something on the first presented slide, but because of language barrier, we can interpret for you. Are there any ones with questions? Okay. So then can we discharge them with a round of applause? Thank you very much for your presentations.
Hello. So as a Ghanaian, I just have to facilitate this to ensure that people hear what we do. Apart from the government, we are civil society, so we share what we've been doing in Africa. And so on this note, I'll call Olivia Ngou, who is one of our key resource mobilization, domestic resource mobilization champions in Africa. Olivia is from Cameroon. Shall we welcome Olivia with a round of applause? And we have our second speaker, who is also French. And so I will be managing, I don't speak French anyway. And so we invite our second speaker to the stage to join Olivia. And when he comes, he tells us his name. Please come to the stage. Shall we welcome him with a round of applause? Thank you. There's supposed to be three. Is there someone who has experience in domestic resource mobilization that will join the panel? Is there someone who can join the panel? It's going to be discussion, so we just put questions, and it's becoming very necessary now in Africa to mobilize our own resources, and we need to learn the strategies that we are all using, whether you are government, you are civil society, you are community, whoever you are, we want to share. Okay, if we don't have, we will start. Thank you very much.
Thank you, facilitator. Thank you, everyone. My name is Dr. Hervé Beinde from Benin. I am the first Deputy Executive Secretary of the National Council that fights against AIDS, TB, malaria, hepatitis, and epidemic in Benin. I am here on behalf of the Executive Secretary, Dr. Anita Wadagni. Thank you.
Thank you very much. Shall we clap for him? So, my name is Cecilia Senu. I'm a Ghanaian. I work with an organization called Hope for Future Generations. I'm also a board member of Robac Malaria in Geneva, and then a board member of the Global Fund. Thank you very much. So I already said that domestic resource mobilization is becoming very necessary. Those of us who have been hearing about Lusaka agenda and the shift, the 5 shifts, is telling us where we are going. This year, US has shown us that it is time to sit up as Africans and own our own resources and mobilize our resources. Our countries are doing a lot, we know, and trying to co-finance and also support. It's also a time that we're looking at donors are also transiting from countries because the financial challenges, ODA, is very limited, and so donors also have their challenges, and so If there is fire in your house, you need to put it off first before you go to another house. And so there is a wake-up call for us in Africa. So my first question, we go to Olivia. Olivia is one of our champions in Africa in mobilizing domestic resources. Recently, the Global Fund has mobilized over $11 billion to fight TB, HIV, and malaria. Gavi also mobilized about $5 billion to produce vaccine for children and also address health system gaps. WHO has mobilized resources to do their work. So Olivia, I want you to share with us some of the strategies that civil society and communities are using to support their governments in mobilizing resources, domestic resources in their countries, and also to support the funding gaps that countries have. Can you share some of the things that you've been doing as civil society across Africa with your country focal persons? Thank you. Shall we welcome Olivia here to speak? Okay, Olivia has the speaker.
Yes.
So the speaker.
Thank you very much. Thank you, Cecilia. Thank you for Ghana. Thanks Ghana for hosting ICASA and for inviting us. And we are extremely happy to be here, especially at this critical moment. So this week it was World AIDS Day, and this week also, today, will be the launch of the annual World Malaria Report that will be launched by WHO. And in this report, unfortunately, we are seeing cases of malaria increasing, and it was the same last year. And then at the same time, as you know, the global funding for malaria, TB, and HIV is at risk. So we are at a very critical moment in the fight against malaria, TB, and HIV. And it's really the time where we need to seriously think about sustained financing for those diseases. So a few years ago, we have started to mobilize civil society to advocate for increase of malaria resources, and also to tell our government that we have never all met the Abuja Declaration goal of investing at least 15% of the budget for health. Many countries have not reached that goal for 20 years. And even that goal is even outdated, because with the current situation for 3 diseases, we definitely need our government to invest more in health. So we have been first building capacity of several organizations in several countries on smart advocacy. We have been developing tools for smart advocacy for domestic resource mobilization. We've been also working closely with different partners. We have one network called GFAN Africa, which is the Global Fund Advocate Network Africa, that we co-host with Waki Health for Anglophone Africa and Impact Santé Afrique for Francophone Africa. So this particular network, which also has as one of the leaders, Mrs. Cecilia here from Hope for Future Generations. So this network has over 500 organizations in Africa who every single cycle of the Global Fund replenishment mobilize community, civil society around advocacy for a fully funded Global Fund. And they do this through signing of letters, advocacy letters to our own government, but also to donor countries. They also do donor countries' embassy visit in their countries. They also write and meet parliamentarians from their countries, but also from donor countries, to really push and insist on why we need a fully funded Global Fund to achieve the goal of the 3 diseases. So this is something that has been done, And this year, the campaign launch was called One World, One Fight, and it's still going on with many organizations still today sending letters and signals to leaders that the 11.3 billions collected so far in South Africa is not enough compared to the $18 billion goal. So there's still a huge gap that needs to be filled, but we are also hoping that our government will continue to increase domestic resource for health. We have to acknowledge that last year and this year, several African countries have increased their domestic funding for health, and we congratulate them for that, but it's not enough. And we really need to make sure that the need of the national strategic plans for HIV, TB, and malaria are fully funded in the countries. So we still need our country to do a lot more, even though they have started to increase a little bit their funding, which we recognize. So in addition to that, we also realize that we need allies. Civil society voices is good, but it's even better when we have allies in the government. So we have been working very closely with parliamentarians, launching for malaria the COPEMA, the Coalition of Parliamentarians to End Malaria in Africa. And we are proud to have Honorable Mark from Ghana here being one of the leaders of COPEMA. And COPEMA today has about 50 parliamentarians from about 10 countries, but is still recruiting more. And they have been doing a lot of advocacy at the country level, especially these days in the budgetary processes, to ensure that countries will have funding for malaria, TB, and HIV, and increase those funding. So working with parliamentarians as a strategy has been highly effective, having champions at the parliament who can advocate for increase of budget, of national budget, but can also open many doors because they have relationship with Minister of Economy, Finance, Health, and some of those key decision makers. And lastly, one of our third strategy is to work closely with media. We have built capacity of media in many countries with all our CSO partners to ensure that they are aware of the problem, the funding gap for the three diseases, but they can also from time to time talk about this and to help to create a better sense of ownership of ending those diseases, but also making sure that the voices of communities affected by those diseases have been heard in the media. So that's what we have been doing in terms of strategy. We have not met our goal. We still have a lot of work to do, but we believe that more than ever, this is really the time for all of us to work together to ensure that our government will take the lead in funding health in Africa, and especially ensuring that we can reach the goal of ending the epidemics for the three diseases.
Thank you very much. Thank you very much, Olivia. Shall we clap for her? I mean, she has said it all. Strategies for domestic resource mobilization. Very innovative strategies that civil society and communities are using across Africa in partnership with COPEMA, our parliamentarians for malaria, GFAN Africa, and Impact Santé, which is being headed by Olivia. Thank you very much. So, from Benin, can you share with us some of the strategies that you also use to mobilize domestic resources, and what are the plans that you have that you can share with us? Thank you. That will mean that you speak in French. Okay, so Olivia will help us in interpretation. Thank you.
Okay. Merci beaucoup, Madame. Et je suis heureux de partager à la suite de Madame Olivia l'expérience du Bénin en termes de mobilisation des ressources domestique et le plan que nous suivons dans ce domaine-là.
Okay, so he's happy to share the experience of Benin in terms of resource mobilization and also share the plan that Benin has for that.
D'abord, il faut dire qu'au niveau du Bénin, notre stratégie de mobilisation des ressources se base sur un support que nous appelons le plan stratégique national pour l'élimination des maladies prioritaires et des épidémies. C'est un plan intégré qui met ensemble toutes ces maladies et permet une intégration en matière de l'utilisation des ressources.
Yes, so in Benin, the resource mobilization strategy is based on a national plan of eliminating diseases, but it's a plan that integrates several diseases. So there's a national plan that Benin is following to eliminate some of the diseases, and this is how the advocacy strategy is based on that national plan.
Voilà, mais ce plan est né d'où? Ce plan est parti d'abord du fait que le président de la République, c'est pour parler déjà du leadership à un très haut niveau, le président de la République a vu très tôt que tel que les maladies étaient suivies, gérées de façon verticale, cela ne pouvait pas permettre vraiment une bonne mobilisation. Et c'est justement pour ça qu'il a créé le conseil qui est le CNLS-TP, qui a donc permis cette intégration qui est devenue une réalité.
Yes, so the plan came from the highest level, from the president himself of Benin, who realized that the priority diseases, so the biggest diseases, could not be eliminated in a fragmented vertical approach. So the president asked for an integrated plan and the creation then of an integrated program so that they will be able to achieve that elimination goal of the priority diseases.
À la tête du CNLS-TP, c'est bien sûr le président de la République lui-même qui a géré la structure pendant longtemps et après a délégué le ministre de la Santé qui est le président. Mais ça, c'est juste une parenthèse. Maintenant, il y a un secrétariat exécutif et ce secrétariat exécutif coordonne donc la lutte contre toutes les maladies et est aussi responsable de la mobilisation des ressources.
Yes, so the president was coordinating that integrated program, but now it's being coordinated by the Ministry of Health, and that program has a secretary, an executive secretary, that is in charge of ensuring that all those diseases will be eliminated, but also mobilizing resources for the elimination of those priority diseases.
Voilà. Du fait que c'est une structure de coordination nationale qui est à charge de toutes les maladies qui fait cette mobilisation et c'est une structure supportée par le haut niveau, ce leadership de très haut niveau est un atout majeur et rend tellement solide cette approche basée sur ce programme intégré.
Yes, so because the idea is really came from the top and is monitored by the president, it makes the program even stronger. And the program then has a lot of power to work towards resource mobilization goals for those diseases.
Voilà, pour aller un peu plus vite, je vais parler des stratégies de façon plus précise utilisées dans la mobilisation des ressources contre les affections prioritaires. Là. Et je vais d'abord compter les stratégies qui sont un peu fiscales, puisqu'il y en a de trois types. Il y a les stratégies fiscales, les stratégies non fiscales, mais également d'autres stratégies qui visent la transparence et l'efficience de la gestion des finances.
Yes, so the program used several strategies to achieve its goal. There are some strategies based on fiscal spaces and taxes. Some strategies are based on non-fiscal spaces and taxes.
Pour ce qui concerne d'abord la stratégie qui vise la transparence dans la gestion du budget et l'efficience, cette stratégie qui est élaborée par le ministre d'État chargé de l'économie et des finances, cette stratégie utilise aujourd'hui plusieurs outils et je vais vous parler de ces outils-là.
Yes, so if you think about the non-taxes strategy, one of them is about governance and ensuring the correct use of available budget. And this strategy is extremely important, and he will explain.
Oui. Il y a d'abord ce que nous appelons le e-budget, et qui est l'utilisation de la planification du budget de façon électronique. Il y a également ce que nous appelons le système de gestion intégrée des finances publiques. Et ces aspects-là ont permis de mobiliser des ressources internes de façon vraiment intéressante.
Yeah, so one of the strategy around governance is the e-budget, so the budget available electronically for everyone to see. And another one is the management of...
Oui, le système de gestion intégrée des finances publiques.
Yes, so it's the system of integration of management of public funding. So all of that is available and transparent.
Il y a également ce que nous appelons le SICOREF. Ce système-là permet de planifier, de mettre tout le budget dans un système important qui permet d'éviter toute perte de ressources.
Yeah, so this financial system allowed all the expenses to be at one place to avoid losing sight of some of those expenses. So everyone has a clear understanding on budget use because everything is available on the system online.
Dans cet ordre, au Bénin, tout est désormais visible par tout le monde. Et puis, nous sommes dans une ère là où vraiment la gestion des ressources est vraiment transparente. En dehors de cet aspect lié à l'utilisation des ressources de façon transparente, je vais aborder le volet fiscal. Pour le volet fiscal, il faut dire qu'il y a certains produits qui sont taxés et cette taxation-là varie selon certains produits justement et ça permet également de collecter des ressources pour la lutte contre ces affections prioritaires. Voilà, par exemple, il y a au niveau de l'aviation, ça c'est déjà un peu plus spécifique. Il y a des produits comme l'alcool, des produits comme le tabac qui sont un peu plus taxés et tous ces éléments permettent de collecter des ressources. Ça, c'est du volet fiscal. Voilà. Mais quand nous revenons maintenant à l'approche non fiscale, nous allons aborder ici le volet de mobilisation lié aux entreprises, au secteur privé. Et je peux vous dire que chaque année, il y a un montant qui est collecté au niveau du secteur privé et qui est dédié directement à la lutte contre le VIH-Sida.
Okay, yeah, so very quickly, because everything is transparent, so budget use, this visibility has really helped to better use the resources. And now the government has also been taxing some specific products like alcohol, tobacco to fund health. And they have even a special strategy on private sector engagement where every single private sector company is contributing to the fight against HIV in particular.
Ce partenariat avec le privé est un aspect important qui permet la mobilisation des ressources au niveau du Bénin.
Yeah, so the public-private partnership is a key strategy that has allowed Benin to increase domestic funding for health.
Pour parler maintenant de la question de plan, il faut dire que depuis que le Bénin a revu son PSNIE en 2024, il y a également le plan de durabilité de la réponse aux affections prioritaires qui est également en train d'être élaboré. Et ce plan est appuyé par aussi l'ONU-SIDA, et permet d'ailleurs de prendre en compte tous les gaps et la durabilité d'ici 2030 par rapport à toutes les affections prioritaires.
Okay, thank you. So in addition, Benin has just developed a sustainability plan for the response to infectious diseases that was supported by UNAIDS, and this plan is going to lead Benin to the end of those infectious diseases and more domestic funding.
Ce que je peux compléter est que au niveau du Bénin, la part du gouvernement dans la lutte contre les affections prioritaires est vraiment augmentée actuellement. Ça, c'est vraiment une note aussi qu'il faut préciser.
Yes, so the government itself has increased its own state budget in addition to requiring budget from private sector and from taxes.
Et pour finir, au niveau du Fonds mondial, par exemple, le cofinancement que le Bénin fait respecte toutes les exigences que le Fonds mondial a demandées.
Yes, and Benin is also a good example of meeting the Global Fund co-financing requirement on time. So congratulations, Benin. Shall we give them? Bravo. C'est bien.
Shall we give them a round of applause? Thank you very much, Olivia and Doctor from Benin. Do we have any question for them? A quick one, because I think our time is fast spent. So maybe we take few questions quickly and we're done up. Thank you. Is there any mic there? Can you please come forward and ask your question? Okay, they are bringing you a mic.
Well, thank you. I can speak in French. First, je remercie les deux présentateurs. Ce que je voudrais savoir, l'intégration que vous avez faite, je veux voir l'impact que ça a changé. C'est-à-dire, vous partez du point 0. Quand vous avez intégré, il y a eu un impact sur les bénéficiaires. Ça, dans votre exposé, on n'a pas vu. On a vu des mouvements de leadership des gouvernements. Mais maintenant, nous ici, nous voulons voir, je viens de la Côte d'Ivoire, Dr Abbé, je veux voir cette intégration-là, quel a été l'impact sur les bénéficiaires. C'est ça ce changement et la durabilité. C'est ça que moi je viens rechercher ici quand je participe à votre séance. Merci à vous.
Thank you very much. We let Olivia interpret.
So he wants to know the impact now of that integration of diseases into one program. What's the impact of that on the ground?
Ok, merci beaucoup pour la question. Par rapport à l'impact, nous pouvons citer quelques exemples. Je vais partir de l'une des affections suivies par le CNLS-TP. Je peux parler de l'hépatite. Pour l'hépatite, il faut dire qu'au départ, le taux, par exemple, de la vaccination des enfants pour l'hépatite, c'était suffisamment faible. Mais aujourd'hui, au Bénin, avec cette intégration qui a permis de mobiliser plus de ressources, aujourd'hui, presque tous les enfants nés sont vaccinés contre l'hépatite. Et c'est un élément important. Aujourd'hui, au Bénin, dans le secteur du travail, il y a des dépistages qui se font pour l'hépatite toujours. Et puis, les personnes, par exemple, qui sont séronégatives sont naturellement vaccinées. Et ceux qui sont positifs bénéficient des traitements selon le cas. Et ça, c'est un élément important que nous pouvons noter ces dernières années liées à cette intégration. Pour ce qui concerne le VIH-Sida, il faut dire qu'avec l'intégration, comme nous pouvons le noter au niveau de notre stand là-bas au Bénin, nous avons des outils visuels qui présentent aujourd'hui le taux, les chiffres que le Bénin a pu obtenir, par exemple, par rapport aux 3x95. Nous sommes aujourd'hui à 89, à 99 et à 91. Mais ces taux n'étaient pas à ces niveaux-là dans un passé récent. Donc le Bénin progresse vers les 3 fois 95. La prévalence du VIH aujourd'hui, avec ces réformes, la prévalence est à 0,8%. Donc voilà des éléments importants sur les bénéficiaires que nous pouvons citer.
Yeah, so in terms of impact, increased coverage of vaccination amongst children for hepatitis. Also in the private sector, employers have been vaccinated and also treated for positive cases. And for HIV, Benin has increased its goal on achieving the 95 goals. So Benin is at 89, yes, 99, and then 91. So has been increased in terms of prevention and treatment for HIV.
Okay, I think we just have to give them a round of applause. The session, they will be among the team. If you have any question, maybe you can ask. It seems we are eating into other people's session. And we have 5 minutes. Is there any other question from anyone? Any addition? Any clarification? Domestic resource mobilization is becoming very important, and throughout ICASA, that has been the discussion. The world is running very fast. I'm seeing one hand up there quickly, and then we move. Thank you very much, Olivia.
All right, thank you. My name is Selassie. I'm a Ghanaian, Afayato South District. I would like to congratulate Benin for whatever they are doing. If what he is saying is not just on paper, but I would like countries to add strict laws for misappropriation of specific funds, which are dedicated for certain diseases. Because sometimes those funds are applied to other things just because they feel this one is not important, and they apply it to something else because it's available. So maybe strict laws should be given out for those misappropriation. Thank you.
Thank you very much, Selassie. It's a recommendation that countries here can take it up. Thanks a lot. There is another hand up there.
Oui. Si vous le permettez.
My name is Andrew from Ghana, Ghana HIV and AIDS Network. Just want to find out how, the question is to the two panelists, how they were able to navigate the competition between CSO networks looking for funding for their disease areas, to be able to have that one voice to chart the common path that they have been able to do. And I believe that even the moderator herself, I was expecting her to give us a little bit of the Ghana content, because I know how she also worked very hard on that aspect. And I know she has a lot of load of, I was expecting that she should have even sat there to give us, to add us more to what they have done, but it's unfortunate it's a process. Thank you very much.
Thank you, Andrew. Olivia is a CSO here, and I've been working with Olivia globally, so she's a champion. We have CSO champions across the world and in Africa, and so maybe Olivia can share briefly. Later, maybe the Ghana CSOs, I will have a meeting and share with you. So whatever Olivia will say is what we do. Olivia.
Yeah, so if I understood, the question is, how do we
CSOs work together to navigate the financial challenges to be able to do their work and also address competition in mobilizing resources?
Yes,
society,
I mean,
maybe speaking with one voice. And
in our experience, we don't have issues of competition of funding for CSOs versus funding for the disease. Many of us, we advocate, for example, for fully funded global fund. Many of those organizations are not sub-recipient of the global fund, but they understand that many of their communities rely on the global fund, especially for some of the key populations in some of the countries that have criminalized law, they totally depend on those funding to have access to treatment, to services. So they understand the need for that. It's true that we are also telling CSOs, your own funding is also important, because if you are not able to work, then we will not be able to increase community voices. So we've done several trainings online, free, for CSOs on how they can mobilize their own funding. And we are also encouraging civil society organizations to think outside the box in terms of funding for their organization, working with private sector, working with other type of donors. So we've been doing a lot of capacity building on that. But we also do advocate to some of the global leaders, some of the global funders, to say that it's important that they invest seriously in community-based organizations, because we believe we cannot end the epidemics without strong community organization. So we do advocacy all over, but so far we have not gotten issues around competition versus the two. But still we have a lot of work to do.
Thank you, Olivia. Thank you very much. Shall we just clap for them again? I think our time is fast spent. And so, like she said, civil society for us, we look at the gap in the countries, we look at the gaps in Africa, and we strategize and call on donors to put money into community-based organizations. Currently, Global Fund, civil society on Global Fund Board has come together to develop strategies for Global Fund funding directly going to communities, and civil society not passing through anybody but go to them directly in the countries. And so we are hoping that GC8, when it starts, civil society will receive direct funding from the Global Fund instead of passing it through even the CCMs. Thank you very much for this. We thank you. Let's continue working and make sure that we support our governments to mobilize resources to address the funding gaps that we have in our various countries in Africa. Thank you very much.